see.
Hi, everyone. I welcome all of you from Papana, Pakistani American Psychiatric Association of North America. This is our lecture series on topics on addiction and psychiatry. I welcome today for this series, I welcome to all of you. And first of all, I would like to introduce myself. My name is Fawzia Arain. I am one of the Child and Adolescent Psychiatry Fellow at Icahn School of Medicine, Mount Sinai Bronx Care Hospital. And here is my co-host, Dr. Yusha Jawad. I welcome him to introduce himself.
Thank you so much, Dr. Arain. It's so nice to have these lectures again. We have been waiting for it. So my name is Muhammad Yushe. I graduated from King Edward Medical University, just working around as a researcher with University Health Network. And other than just looking forward to applying for psychiatry residency this year. And over to you, Dr. Arain.
Okay, thank you. So now I would like to invite our speaker today, Dr. Nauman Ashraf. Dr. Nauman Ashraf is the program director for Kansas City University GME Consortium Ozark Center Psychiatry Residency Program and Addiction Medicine Fellowship Program in Joplin, Missouri. He serves as an adjunct clinical associate professor of psychiatry at Kansas City University. He also served as the medical director of addiction services at Ozark Center and established Ozark Center's outpatient buprenorphine treatment program in 2017. He completed his psychiatry residency at New York University School of Medicine, as well as his fellowship in addiction psychiatry. He is board certified in general psychiatry, addiction psychiatry, and addiction medicine. And he is also the recipient of the Harold I. Kaplan Memorial Award. That is a prestigious award for outstanding contributions in the field of psychiatric teachings and educations. He serves as for addiction medicine. He serves as prescriber consultant for the SAMHSA STRTA Consortium to help fight this opioid epidemic. He also served as the PI for KCU-GME Consortium funded projects, and that is called 5-factor wellness model and to improve wellness for all residents. That's why we have invited him as a speaker to teach all the residents and fellows and the psychiatry applicants. He has been invited as a speaker to multiple conferences and has given media talks on the treatment of opioid use disorder. So I welcome Dr. Nauman Ashraf. Thank you.
Okay, G, thank you, Fawzia. Thank you, Yushe. Thanks, Papana, for inviting me for the talk. And let's see if I can share my slide here. Okay, can you guys see it?
It works all well. Perfect.
Awesome. Well, let's begin then. So, assalamu alaikum, everyone. And we have, so we're thinking about what should we do. So I thought maybe let's talk about, it's a huge field. I mean, it's in itself, where do you pick from the substance use disorder? So maybe let's do an overview of some of the concepts in addiction, the reward circuit, those kinds of things. And then what are some of the approved FDA available treatments? So I thought that we can just go through some of the overview. The only disclosure is that I work for SAMHSA STRTA program as a prescriber consultant. So we'll touch upon the neurobiology of addiction. We'll see reward pathway, how it works. And there's a newer understanding of the anti-reward pathway, which you guys will hear more in the future, but that's where the research is going to focus more now. So we'll touch upon that. Risk factors for addiction, and then what are the FDA approved medications for? There are 3 disorders that we have FDA approved medications for: alcohol, nicotine, and opioids. So we can touch briefly upon that. And for others, it's just mostly off-label and then therapies. So what is the prevalence? Just a snapshot. The data came out actually in 2022, but when I accessed it, but this is from 2018. So it takes time for the data to collect, and then they analyze, and then they post it. But just to look at like bird's eye view, what is the prevalence of marijuana? 43.4 million, methamphetamine 1.8, ecstasy 2.5 million, LSD 2.3, heroin 0.8, crack 0.75, cocaine 5.5 million. So that's just rough prevalence. And then some of the key stats, about 700,000 drug overdose deaths in the US since 2000. Then $35 billion federal budget is spent for drug control. That was spent in 2020. 19.4% people have used illicit drugs at least once. And the CDC figure, you guys probably know, upwards of 135 people die every day from opioid overdose. So those are some of the issues that we are tackling and why we want to understand what is the disease of addiction and how we can help it. What is the economic impact if people are using drugs? So there is a cost of buying drugs to the individual. So if someone is involved in using drugs, they have to buy it from the dealers, and dealers will charge them money. So that's one thing. Then there's loss of productivity and income. Anyone who is struggling with the disease of addiction, they are not able to work. So when they're not able to work, they're not producing anything. They're not a healthier part of the community at that point where they are contributing to the community. And their income, of course, suffers when they're not working. So that has impact on their family, and then that impact goes out of the family to the community at large. Healthcare and legal issues. With some drugs, people can have health problems. Like alcohol can ruin any organ of the body, but most commonly you may have seen patients with liver cirrhosis and with, like, they come in with vomiting, esophageal issues, pancreatitis. And then if someone is shooting drugs, they can throw emboli, can have endocarditis. So multiple organs can be involved. Alcohol can also cause brain damage. Legal issues, if they get caught while they're transporting the drug, then they can serve in the jail. And so that becomes a problem. The drug trafficking, if they're involved in that and they're selling the drugs to gain some money, then that is another issue. And then eventually the society has to bear the cost. If we are going to treat those patients, they're going to be in the hospital. Again, they're not working, so they're not contributing anything to the community, but we have to take care of them as they're members of the community. But you do it by taking money from your other budgets, federal budgets. So in the hospitals or rehabs or shelter homes, wherever they are, that is added cost to the community. Is addiction a moral illness? So in 1980 or prior to that, there was this notion that's a characterological flaw. Someone who is a weaker person, it's their choice, it's a habit, and they make the choice, they pick up the drug and they use the drug. That unfortunately has still continued. A lot of people in the society, you would hear, they still believe it's a moral illness. You should be able to control it, and it has to do with your weaker character. There's something lesser about you, that's why you do it and we don't do it. But our current understanding, based on all the research, it's quite the opposite. The research says it's a primary chronic brain disorder characterized by compulsive substance-seeking behavior and use despite harmful consequences. So people know that it's not going to be healthier for them, and they're still using the drugs. So they know the harmful consequences, that they may have issues with their family, they may have issues with the legal department, they may not be able to keep their job, they may have health problem, but they still cannot control the use of drug. And that's the definition of addiction. And that's happening because it's a chronic brain disorder. There are changes in the brain. That is why they cannot stop using. It's not because of their choice whether to use or not. This is just a treatment comparison with other chronic medical disorders, just to make that point, bring that point home. Substance use disorder relapse rate is 40 to 60%. But if you look at diabetes, it's 30 to 50, hypertension 50 to 70, asthma is 50 to 70. So it just behaves like any other chronic disorder. It's not different if you look at the pattern of disease. What are some of the risk factors? We always talk about biopsychosocial risk factors. And so biological would be genetics. If parents used to use drugs, you may inherit some of the genes. They may code for certain proteins and have expressions in the brain where you are more prone to using drugs. So your brain is wired a little bit differently. Lack of attachment and nurturing by caregivers. When we all are growing up, we have the disappointments that we go through. But when we are disappointed, when we are crying, when you're depressed, there's someone that you need a mothering environment. So usually your parents are around, they provide you that support. When they provide you the support, you internalize their support over time. And when you grow up and you're not with your parents and now you're depressed and alone and you have this negative, miserable feeling, you can call upon that support. And that's what we call resilience and our coping skills. And then soothe yourself. You don't need the external person to help you. But unfortunately, if you didn't have that kind of upbringing, and if someone was neglected, or on top of it, if that person was abused and had traumatic um, uh, upbringing, then it's what happens is they are in this miserable state and there's nothing that can soothe them now. So then they go towards drugs, and drugs can help them and calm them down. So that's one of the reasons they're trying to find that attachment. And unfortunately, drugs become the attached object. Untreated mental illness, people who are struggling with some sort of mental illness, but they're not treated. They come across some drugs, and when they use it, they feel good. Like opioids are good antidepressants. Alcohol is a good anti-anxiety medication. It's also a good sleep aid. Similarly, the stimulants for ADHD. So these will work. It's just that you don't know the dose you're using and the harmful effect that you're getting from these drugs, but they work on the same receptor. So you will have some benefit. So when these people use the drugs or they come across and one time they use it, they're like, oh, wow, I feel like quote unquote normal for the first time in my life. And they start using those drugs. So it's also important to help them out and find out. And that's one of the part of the assessment that we do is whether if they're presenting with, say, depression, anxiety, whether these problems started before drug use or they started after the drug use. And you have to clarify it. And if they started after the drug use, or you cannot ascertain when they started, you at least need to give them 30 days and then reassess and find out if the problem is still there to qualify as a substance induced or versus like a organic disorder. So, and that's the whole thing that I explained is kind of called the self-medication hypothesis. And I have a slide on that, but basically people are trying to treat their own illness by using drugs. Peer pressure is another important reason. Most commonly, you see it in teenagers when they are at school and colleges. Their friends are using, they want to be part of that group. They don't want to be socially isolated. So they get under that peer pressure and they start using the drugs. Psychological abuse or trauma. So psychological factor, when we talk about biopsychosocial, if someone had trauma, abuse, and they have negative feelings now, they're struggling with depression, anxiety, they may turn towards drugs to calm themselves down. Social factors are isolation, poverty, interpersonal conflicts. If those things happen, they can also serve as the triggers for drug use. With all these factors, suppose someone who has had the perfect upbringing, they had no issues, biologically, none of the parents use, they did not have any trauma growing up, socially they are good, and they don't have any mental illness. Can they still become addicted? That the last factor would be the use of drugs. So if someone who had everything good, but they were given a lot of drug or the environment, they kept using it, the brain will get dependent on it. So it also depends on the use. So this was a self-medication hypothesis. Kantian brought this forward. Individuals use drugs in an attempt to self-medicate their distress and suffering. Basically, if they are struggling with, like, say, anxiety, depression, ADHD, and they have anxiety and they're looking for something and they come across a drug, they use it, they feel good, they continue using it. There's a Swiss cheese model of addiction. A lot of time people would ask, what is why different people are different. Some will get addicted sooner, some will not get addicted after using the drugs. What is the reason? So the reason is in this Swiss cheese model. Everyone has got different upbringing, as I was talking about, and that sort of gives you protective layer of these cheese slices. So somebody had a good upbringing at home, they had a strong cultural environment where they were raised, their society was very good, and they had good values, and then they may have spiritual and religious values that help. So these are multiple slices of cheese now you got, as opposed to someone who only has one slice. So then if they get exposed and they use drugs, that needs to get through all these slices of cheese. And that's why some may be more resistant to becoming addicted after, just even after like a 2 or 3 times use, as opposed to others who get more addicted. Also, the holes in the slice are, when you use drugs, these holes enlarge, as opposed to when you do some better activities, like say exercising and get into healthier activities, these holes start closing. So it's important to sort of keep in mind different people will react differently to drug use because of their resilience and how their brain is wired. So functional brain imaging, just to highlight the same point, it's a chronic brain illness. So sometimes if you have to share this with your patients, you can show it to them, there are brain changes. And the other answer in this slide is it reversible? Yes. So if they stop using drugs, there are chances that the brain can reverse the changes. So on the left side, you have healthy control. The red and the yellow areas are the active areas of the brain, normal brain. Somebody who used methamphetamine, after 1 month of abstinence, you cannot see red and the yellow is decreased. Then, but if they've been abstinent for 14 months, it starts coming back. So there's recovery in the brain. On the right side, we have the PET scan where you have the control that shows the utilization in red color. So the brain is healthy, it's working. On cocaine, that goes down. So when you're using the drug, it affects the brain. And then if you are abstinent for a while, it starts improving. Now in methamphetamine case, it showed that after 14 months, it starts to look like getting back to the normal where the brain was. Wanted to talk about a stigma because we do have really good treatment options for addiction treatments, but unfortunately they're underutilized. And one of the reason is a stigma with the patient population, but also doctors have some stigma in treating this population, and the society has a stigma, and all these barriers then come in the way of treatment. So influenced by whether you think someone is to blame and whether they have control over the behavior. When you believe somebody has a control, that means it's their fault. It's not a disease. You're moving away from a disease model. You're moving more towards the moral illness model. It will decrease when you understand it's not their fault. They cannot help it because now there are brain changes. Similarly, if someone has hypertension or other diseases, you can tell them about precautions, but they can't help if they've got structural changes in the body. You have to treat them from the medical model. So there's a stigma within the patient. They blame themselves, they feel guilty. There's outside stigma where society feels it's a moral illness, a moral failing. And then clinicians, some clinicians believe that the treatments are not effective. So we have very good treatments. And again, it's just a hard population to treat. There are relapses in this population, so people give up sooner. But again, if you put it next to any other medical model, you will see the same thing. The slide I showed earlier in terms of relapse rate, it's right there with diabetes and hypertension. How many times in the hospital we see those patients with diabetes who are coming back because they did not take their medication on time, or they're eating too much, and then they're back in the hospitals, or like the cases of cirrhosis. I remember when I was an intern, how many times we had to tap the same patient because they will not follow the instruction, or it's just the disease is progressing and they're back in the ED. Similarly, the patients are struggling with the disease of addiction. That's what happens to them. Some of the terms that we should avoid that are stigmatizing when we're talking to our patients: addict, abuser, junkie, user. It's better to use like a person with a substance use disorder. Similarly, if you get the urine toxicology saying that it's a clean or dirty, put some sort of a judgment rather than say it's negative for these drugs or it's positive for these drugs, or patient is abstinent, patient is substance free, patient is actively using, those kinds of terms. Similarly, habit or drug habit, because then it's a habit, you can control it. Rather than using that, you use substance use disorder, regular substance use. Opioid replacement or methadone maintenance. So when we say it's a replacement, then people believe that we are replacing one drug with another drug. And I have a slide and we'll talk about it, why that's important. Rather, we should call it, it's a medication-assisted treatment or medication-assisted recovery. It's not a replacement for one drug with another. So if stigma erodes the confidence, the substance use disorder is valid and treatable health condition, creates barriers. So if someone is labeled with substance use disorder, since we have stigma in the community, it's very hard to get secure jobs, get housing, get into relationships, and then also stops people from seeking help. If you want to do a survey today, go to any school and ask them how many people are using drugs. It'll be very hard. Like say here, the things are changing. Go back to Pakistan and ask any good university, how many of your kids or students are addicted to drugs? They won't give you the good data, but we all know there's a huge use of drugs on the campuses. So stigma will stop people from talking about it, and then they won't even seek treatment. Similarly, if someone is struggling with the disease of addiction, their parents would not be comfortable accepting it and bringing them forward for treatment, because that means that they've got somebody who uses drug in their house. So that's what stigma does, and these people don't get treatment. Natural versus drug reward. So normally our brain works where we need reward, we need dopamine, right, for motivation and to feel good. And if we talk about food, say, I mean, we got the student, I think, from all over. So let's pick, like, say, provinces, because there's some food that are really popular in provinces, right? So you go to Sindh, you talk about like biryani, halim, nihari. You go to Punjab, you talk about pie, like Balochistan, saji, or like KPK, their shinwari kadai, their charsi tikka. These bring some sort of joy. So people who are foodies, they're right now feeling something, right? When you talk about it, that's the dopamine tick. Now, what if you get to eat that right now, right after this lecture? That's going to give you jump in your dopamine. But if you look at the graph, the jump is only going to be 150% from the basal dopamine output. As opposed to if you look at the amphetamine use graph, that jumps it up to 1000% of the basal release. So how do you match it with the normal reward? There's no way. That is why these people are using it, because the reward is so good. The pleasure is so strong that you can't bring anything from normal life situation that's going to give them that much high. That's why they use it. And if you go to methamphetamine and ice, researchers believe it jumps it up to close to 4000% of the basal release. That is why, if you have heard, it's a huge problem in Pakistan these days of ice use, especially in Karachi. A lot of kids are using it. So brain's reward center, how does it work? What is the neural underpinning? We get signals from the ventral tegmental area of the midbrain. It gets relayed to the nucleus accumbens in the limbic cortex, and then nucleus accumbens releases dopamine. That is the final common pathway for all drugs of abuse. That's where you need dopamine to feel good. All the drugs of abuse, doesn't matter which receptor they're using, eventually they have to conclude here and release dopamine, and that's how people feel good. This nucleus accumbens, if you notice, is also close to amygdala. That's the seat for emotional memory. So when you are feeling down and you had a breakup, you feel depressed, you feel anxious, that miserable feeling gets registered. And what helped in that feeling? The crack that you use or the alcohol that you use. So that memory gets registered. So next time when you feel down emotionally, amygdala has that memory. Hey, you can do this. That will relieve you. Similarly, hippocampus has the other memory. How did you acquire the drug, and how did you use it? So that's going to help you too to go and get the drug. So these parts of the brain working like closely to each other, that they are keeping the emotional and the other memory, situation memory of the event, and nucleus accumbens is releasing the dopamine. The higher brain circuit, which is the cerebral cortex, is right here at the top. That provides the inhibitory control. That's the one that tells you it may be bad. So understanding it in a way where your lower brain, nucleus accumbens, is like we call it like an animal brain, lower brain, or if you take the psychodynamic example, it would be the id, center for the id. And the higher brain, cerebral cortex, would be your superego. That's the one that is formed through your parenting, your culture, your laws, and what is right, what is not right. So cerebral cortex will control the behavior, tell you whether it's good or not. And nucleus accumbens is, if you don't have cerebral cortex, it's like an animal. If it wants something, it wants something. So that is the balance in the brain, and we'll talk more about it. The neurotransmitters that are used, again, dopamine is the final common pathway. We have D1 to D5 dopamine receptor. We have the serotonin receptor. We have cannabinoid receptor. We have opioid receptors. And I've listed their functions as well. But those are the receptors in the brain where most of the drugs work. And then they will, and then there's acetylcholine for the nicotine. And then they will converge on the dopamine release. Now that's the slide that's most important and most complex. So we'll spend some time on it, but this will tell you the understanding where we are right now, where we are moving in the future. If you look at, say, the left side of the brain, the nucleus accumbens, ventral tegmental area, amygdala, hippocampus, they are very small. And the prefrontal cortex is bigger. So normal brain, when people are not using drug, that's what it is. Your drives are in check, and the prefrontal cortex is telling you what's right, what's not right. And it works fine. When people get addicted to drugs and they keep on using them for a while, these areas, they keep growing up because the reward is so good, right? We said it goes to up to 1000% of the basal level. So people like it, they want to use it. So the amygdala grows up, the hippocampus is bigger, nucleus accumbens, ventral tegmental area, they're all big. When they are bigger, then what happens, the prefrontal cortex eventually starts losing its grip. So that shrinks. And then your lower areas of the brain take over. When they take over, that's when you have heard the word, people say the brain is hijacked by the drugs in addiction. That is what's happening. This is the hijacking of the brain. This is at the neurobiological level. Initially, the reward area or the animal brain is smaller than the saner brain, but then eventually it grows, it takes over the saner brain, and then you lose control over it, and you cannot control drug use. The drug controls you, and that is the definition of addiction. The moment drug starts controlling you is addiction, and that's when you make the switch. Other areas like anti-reward circuit is important. Anti-reward circuit gets activated when people are feeling negative, they feel miserable, they have anxiety and depression, then it gets activated, and it wants to prevent more pain to the body. So how does the disease of addiction start? Initially, it's a phenomena of positive reinforcement. What is positive reinforcement? You add something to the environment and you get the desired behavior increases, right? Give candies to the kids, and if they're doing something good, the behavior increases, positive reinforcement. So when people take drugs initially, they feel high. It's positive reinforcement. They want to feel high, they want to feel good. They take drug, they feel good. Negative reinforcement is you add something to the environment that takes away the unwanted behavior or unwanted thing in the environment. So in this situation, what happens initially, people are using drug, they're getting high, it's all positive, they're good. But once the body and brain become dependent on drugs and they do not have the access to a drug, they start withdrawing. When they start withdrawing, they feel really bad. They have diarrhea, they have vomiting, they are sweaty, they cannot concentrate. So now it's painful for them to be in that state of withdrawal, and they cannot work because if you are in the state of withdrawal, you can't concentrate, you can't, your attention span is gone. So you can't go to the work, you can go to the school, and that's why these people cannot really do well in school. So one of the things is when people start falling their grades, you need to see what's going on. Is there something psychiatric illness going on? Is there addiction going on? What is the problem? What's happening? So that negative reinforcement, what happens in this, now that patient is taking the drug not to get high, to avoid the unwanted withdrawal effects. So that is negative. So addiction changes from positive to negative reinforcement. So the person who is now addicted and going through withdrawal, he is not enjoying drug use. He has to use it because he can't function without it. And that's the miserable situation. And that's why we should be empathic towards them. They're not using to get high. Their brain is now been taken over by the drug, and now they have to use it. They have no other choice. Otherwise, they won't feel normal. The third structure that's mentioned is intrasuption or insula. That's another newer area of research for us that probably we'll hear more about. But basically, intrasuption is there are so many things that are happening in our lives, but we don't pay attention to it because we are able to put them at a distance. So suppose one example that's given, if I give you all of you like 10 seconds and tell you to close your eyes and just pay attention to any feeling you have in the body. If you have to go to the restroom, if you're thirsty, you have to drink, anything that you feel, and one of you can share what you felt, and then we can talk about the concept a little bit more. So just 10 seconds and see, is there anything that you're feeling? Okay, if anyone wants to type in the chat box, thirsty, right? So, and there could be lots of feeling, right? So it's not like you are feeling thirsty because I told you to close your eyes. You were feeling thirsty all along, but you were not paying attention to it, right? You're more focused on the lecture and you're paying attention here. Similarly, some people would say, oh, I'm hurting, my back or my neck is hurting, so I need to stretch. It's probably hurting and you were tired, you're in a one posture, but you didn't pay attention to it. So insula gives the meaning to all these impulses. So there's a thought, you can have all the wrong things on the right side of the brain where your nucleus accumbens is telling you to use. The prefrontal is saying, no, don't use. And there's so much confusion in the brain. But unless insula gives it a meaning that it's craving and go and use, person will not use. So that may be important. And there may be a more future role for insula in the future as we study more in terms of regulating. We may have impulses, people may be having these kinds of things, but if it's not given a meaning, they won't use, they won't know that this is craving. What works at the insula level is mindfulness. That's exactly what mindfulness does. When you are in a moment, you may have heard about, like in borderline personality disorder patients, when they have an urge to cut, we tell them this is going to go to the top, it's going to plateau, and it's going to go down. You just have to be there in the moment and ride the wave. Well, riding the wave, how do you ride it? You ride it with mindfulness. So you calm yourself down, you recognize all this is happening, and try to focus on one point, breathing, eating, whatever, mindfulness works for you. And then the wave goes away. Maybe that's what happens with addiction too. You have cravings and you do mindfulness and you relax and you make your insula stronger and you don't go and use. So these are, you will be hearing these terms, anti-reward and insula, a lot more in addiction in the future. Okay, so this is just a game to illustrate the point for the reward system. The first one is, if someone tells you there's a sure gain of $250, like you get $250, that's it. And the other is, if you want to gamble instead, you have 25% chance to gain 1,000, 75% chance to gain nothing. So, and you can have your own answer, which one you want to pick from this. The stats show majority, about 83-84% of people will pick A. They will take the sure gain. They're not going to gamble because they don't want to lose anything. Here, you got nothing to lose. You got 250 and they walk home. So this is positive reinforcement, the dopamine circuit. Use the drug, feel good, right? That kind of circuit. It's a reward circuit. The second game is talking to anti-reward circuit, where you have a sure loss of $750. You're going to lose that. Or you can gamble. You have a 25% chance to lose nothing and 75% chance to lose $1,000. If you don't want to play, you have to give me $750. Otherwise, you can play and see if you save that money. Majority, upwards of 80%, will take the option B, because this is how our brain works. They will try to avoid any painful event at any cost. And that is what's happening in negative reinforcement. They're using drugs to avoid the withdrawal effects. And that's how the brain psychology works. How do you recognize addiction? There are changes in sleep. They're sleeping more or less. You should pay attention to it. Somebody's appetite changes. Their mood swing. They're irritable. They're throwing fits. They are withdrawn. They're very suspicious. Some drugs like cocaine, stimulants will make you feel paranoid. So a kid comes home and pulls up all the curtains, turns off all the lights of the room. You need to pay attention to what's going on. Maybe that person is paranoid and being monitored. out of character behavior, spending money, working on multiple projects like manic behavior. A lot of drugs would do that. Track marks if they're using IV drugs, drug paraphernalia, if you find needle and other drug residue in their room. Suppose if you're talking about a kid and talking to their parents and explaining them, alter physical appearance because now they're using, so they don't have time to pay attention to themselves. So those things will start declining. The academic performance will start declining. They may have withdrawal symptoms like shaky hands, bloodshot eyes, and things like that too. What is the definition for substance use disorder? You need more than 2 items in a year period whenever they happen in the last year. Failure to fulfill responsibilities. Again, if they're using, they're not being a good member of the family, they're not going to the school, they're not working. Cravings is very easy. Most of the people who are addicted, they have cravings. Social interpersonal problems, since they're busy using and acquiring drug, they do not see their friends. They are not socially active anymore. They use larger amounts or longer than intended. Initially, when people start using drugs, there's a phenomenon called tolerance that develops. Our receptors change. There's down regulation. So you need more of the drug to have the same response. So people use more and more. They try to cut down. They cannot, because by this time they have moved into the negative reinforcement cycle. So they can't cut down. They have to use it to feel normal. They spend more time to get, use, and recover because the use has increased. They give up their normal activities of life. They use despite problems, ongoing use. And they also use in like physically hazardous situation, like somebody who drives a public van, school van, somebody who works with machinery. Those are the conditions where you can have serious issues, but they still continue to use. And then tolerance and withdrawal are the two ones. If something is prescribed, then you won't include tolerance and withdrawal because that is sort of iatrogenic. If you give any drug that has dependency properties to any patient, they will become tolerant, and if they stop, they will have withdrawal. So to diagnose use disorder, you won't include item 10 and 11 if they were prescribed the medication. We have different classes in DSM-5 for substance, so alcohol, caffeine, cannabis, hallucinogens, inhalants, opioids, sedative, hypnotic, anxiolytics, stimulant, tobacco, but there are also behavioral addictions, and they keep increasing. So gambling, internet addiction, sexual obsession, shopping addiction, etc. Treatment approaches historically, what we have done in terms of therapy. So they started off with psychoanalysis, and Freud wanted to do it. But what is the problem with psychoanalysis? The idea of psychoanalysis is that you have to bring their defenses down. So you have to tone down the upper brain, prefrontal cortex, so their id and their lower brain and their desires can come out, so you can work with them and resolve the conflict. That's the whole point of doing it, so people can express what they're feeling. But in addiction, that's the opposite. In addiction, we don't want the id to come out. We want the prefrontal cortex to be stronger. So that's why it did not really work for addiction. Then they tried confrontation, boot camp, trying to attack the denial of the patient, and that did not work out. So the modern approach is medication, and we'll talk about what are the medications that are approved, counseling approaches, psychotherapy, and mutual help, like the 12-step program where people who have struggled with the same illness, they come together and they help each other. Those things have shown good evidence. What are the goals of the treatment? You want to enable an individual to reduce or eliminate drug use. You want to address associated physical or mental health problems, so any comorbid issues, and then restore the patient to maximum functional capacity. These are the treatment goals for any addictive disorder. We would like them to be the functional member of the community, and then control their cravings and get a hold of their illness. And if there are any associated problems, take care of those too. So for opioids, the FDA-approved medications are naltrexone, which is an antagonist at the mu receptor, acamprosate, which works at the glutamate receptor, and the disulfiram, which is it blocks the enzyme in the alcohol metabolic pathway. So those are the three that are approved. They're very good, but again, unfortunately, not utilized that much. For the medications for opioid use disorders that are approved are full agonists, which is methadone. Then we have a partial agonist, buprenorphine, and the antagonist at the mu receptor is naltrexone. So the point I said I will come back to it is treatment of opioid use disorder, replacing one drug with another. So you are not replacing one drug with another. What you're trying to do is treat the maladaptive behavior of the drug. Think about, and this is why I included it, because a lot of people come in and they're like, well, my family member is struggling, but what you are doing is you're telling them not to use heroin, but you're giving them methadone. So it's like they just replace one drug with the other. So what's the point? So the point here is, if you think about someone who is struggling with the disease of addiction, start with the morning. They get up in the morning. If they had used the day prior, they are going through withdrawal. So what do they have to do to prevent the withdrawal? They have to find drug and buy drug from a dealer. To buy drug, they need money. If they have initially money, they will utilize their money. If that runs out, they'll go to their family members. They go to their friends, and you can only ask for 2, 3, 4 times. After that, they would say, no, we can't give it to you because you're using it on drugs. And that's, you may have heard the phrase, people say they've burned their bridges. That's how they burn their bridges. 1, 2, 3, how many times somebody's going to help you out? So then what do? They steal, they lie, they cheat. They have to get the money because they are struggling, suffering now. They get the money, they find a dealer, they obtain the drug from the dealer, and now they have to transport the drug. It's an illegal compound. So if they get caught in that transport, they go to jail. Then they have to find a safe place to use the drug. When they're using, they're high, so they can't function at that point. And then once the use ends, then they may be able to do something. So what kind of job can they do? What kind of study can they do if the entire day is spent on that? And then after a while, they're going to go through withdrawal. This is the life of someone who is struggling with addiction. We are trying to break this cycle. When we give you medication, you come, you take your buprenorphine in the morning, that's it. You go to work. You don't have to worry about it. You get up in the morning, take your buprenorphine, you are done. And nowadays there's an injection called Sublocade. You just go to your doctor once a month, get the injection, and you are done. Just go about your normal life. That's what we are doing. It's not replacing one drug with another. There are FDA approved medication for smoking cessation. So NRTs, nicotine replacement therapies, are very popular. Gum, and then the patches and lozenges and inhalers. And there's a combination treatment that you can try, and that's very effective. Varenicline is the partial agonist at the nicotinic receptor, and bupropion is the NDRI, norepinephrine dopamine receptor inhibitor, so reuptake inhibitor. For psychotherapy, what do we do? What's kind of evidence-based? Cognitive behavioral therapy works, and the main understanding is that our thoughts can affect our behaviors and then our actions. So if we have normally, like in depression, people who have negative thoughts, we try to help them think positively. In addiction, if people have some triggers that lead to relapse, we help them recognize those triggers. So be in touch with their thoughts. So suppose somebody who is isolated over the weekends and feels depressed because does not have a family or friends to hang out, relapses, can pay attention to it, to his thoughts or her thoughts, that whenever I feel like isolated, or whenever I am not social, or I go like lock myself in the room, it leads to the negative cycle of emotions and leads to my relapse. So if they are in touch with their emotion, they can do something about it. Similarly, group psychotherapy, we talked about, if people can attend like big groups, and there's a facilitator who can talk about it, talk about their struggles, that has shown that also helps. And there's a power of other people who attend the groups, like a social community helping. Contingency management, if you are doing well, then you are rewarded. So the older understanding with addiction was, and a lot of people still have that model, if you are coming to see me and you're still using, I'll do your urine toxicology, and if you come back positive, I'm going to give you a warning. You come back positive again, I'm going to give you the last warning, and then the third time I'm not going to see you. That's how it used to be. And now contingency management is actually kind of opposite, because it's like, if I see you and we get your urine and it's a negative and you're not using, I'll give you a reward. So if you're marijuana user and your marijuana, 2 of the urines consecutive are negative, I'll give you a voucher for Burger King. I'll give you a voucher to go watch movie. So this is a little bit different approach and works very well for stimulant use disorders. Motivational interviewing is a technique where you have a collaborative approach with the patient. So The older approach is a prescriptive interviewing. Prescriptive is your patient goes to the doctor, you look at their labs and you tell them, oh, your lipids are very high, your weight is very high, your blood pressure is high. If you don't do this, you're gonna have bad consequences, you're gonna die. That's it. One way, tell the patient, and that's it. Probably works for very few patients, majority doesn't work. And in addiction, it doesn't work. Motivational is not about you telling them. Motivational is that you help them see what problems they have. So it's all about creating more confusion in patient mind, creating ambivalence initially, and then resolving it. So like, okay, well, you're just talking about one side of it. The alcohol helps you go to sleep, helps you with anxiety, helps you relax in the social setting. What about other things? Anything else happen? What about your kids who are in the DFS custody? What happened there, right? What about your liver? What about other things? So you have a conversation with them, just like in a collaborative model, have them identify there are other things too, and then they come up with a plan. If I want to stop, this is what I can do, this is what I cannot do, and let them take control of their plan. That is motivational interviewing. So everybody has a motivation to change. That's the premise. We need to find what is their motivation to change, basically, rather than telling them what to do. Mindfulness, I already touched upon, just focusing on one point and try to relax. The best example would be in any spiritual culture, praying would be one of the examples, mindfulness. Mutual help facilitation, like 12 step has a really robust evidence base for alcohol use, and Alcoholics Anonymous has a very good data. So it works. People over there, they know you when you're starting to have issues and going to go down relapse because you look different, you're not taking care of yourself. They are sponsored, they come forward, they take care of you, they tell you how they struggled with this, how they came out of it. It's a very positive treatment. Okay, so take home points. The substance use disorder, opioid, or any disorder, they're treatable chronic brain disorders, and people can and do recover from them. And keep calm and don't judge. And we can now take questions.
Thank you so much, Dr. Nauman Ashraf. In such a short time, you compiled everything, the mode of action, how it happens, what is the reward system, along with the neuroanatomy that you revised. Thank you very much. I would like to go with the questions. I will be inviting, so it is easier to ask. Who would to ask first? Umar has, I can see Asim.
Hi, thank you so much for this wonderful presentation. I had a couple of questions, but I'll just ask one for now. You mentioned the Swiss cheese model and how the holes can increase depending on how many levels of support you have. So I wanted to ask, in terms of the substance use, what factors of substance use contribute to the enlarging of the hole in the Swiss cheese model? Thank you.
Right. So substance use would be your use of the drug if you're just focusing on that. So Swiss cheese is different, but I'll just answer the question that you asked and then explain it because that has to do with the resilience and coping. So like if they're using some drugs, there'll be changes in the brain. The areas I showed, the lower brain will enlarge and the dopamine circuitry will change, and there's neuroplasticity. So if the same neurons being used at the same time over and over, the brain gets rewired in a way where it's ready for another time when they use it. So that's what I meant by, so if they're using it more and more, there's they're prone to having a quicker response next time. I think the Daniel Siegel's thing that the neurons that fire together, wire together is probably relevant here. So if that happens, now the Swiss cheese is basically has to do with why some people become addicted sooner and for some it takes some time, and that has to do with the slices of cheese and how porous their slices are. So if someone has better slices, they come from a family where they were cared for, they didn't have any traumatic event, they are going to have better chances of doing well as opposed to others who had trauma, who had neglect.
Thank you.
Sure.
Thank you. Yes,
I think Dr. Fozia's mic isn't working. So
Azim Rao, I can see.
okay, I think I'll take over for a bit. So I would ask Mr. Azim Rao, you can go ahead and unmute your mic and ask the question.
Many thanks. Great talk, Dr. Nauman. Very glad to be with you all. I work in here in Islamabad, and I just want to ask you, how would we will be convincing the patient, because the patients who are abusing drugs, they get admissions for shorter term and long terms, and the cycle goes on. And what is the good convincing evidence that we may tell the patients and their families that perhaps this is the only way that you need to come to us, or for shorter term or longer term, along with whatever you have described with the psychoeducation and motivational interviewing, whatever we keep doing. What is the advantage of admitting them for shorter or longer term?
So the advantages of admitting is like how the rehab model came about. You're keeping them away from the drugs. A lot of time you guys would notice, so when we drive a car, are you paying attention to what you're doing when you're changing the gears? You don't pay attention to, right? It becomes automatic, reflexively, like your spinal reflex mechanism. Similarly, when people are using drugs, it becomes part of they get conditioned to it, and you have to break that cycle. So if somebody who, when they go home at night or in the evening and they pass through certain street and that's where they meet their friends and they use drugs, it's very automatic. How do you break that cycle? So bring them into the rehab, away from that environment, to break that conditioned response, give them a month-long treatment or 21-day. And then during that time, that's when they're not using drug, give a chance to their brain to kind of start recovering. And you can have a talk with them, because when initially, like the first detox phase, 5 days, 7 days, you may not be able to get much farther because they are withdrawing and their brain is not there to really absorb the information you're giving. So you have to keep them for a longer period, and then you do motivation interviewing there and other things. But I think the first thing would be to break the cycle of the use, to break those conditioned responses.
Many thanks.
Great. Yasir Masood, you can go ahead and ask your question.
Yes, hi, Dr. Nauman. Great talk nonetheless. I just wanted to ask you, how frequently do you see interactions among substance use disorders and suicide or suicidal ideation or suicidality among adolescents who frequently report drug use? And if someone comes with a suicidal ideation or suicidality, do you refer it to a certain department, or do the same techniques work for the one which I had mentioned for substance abuse? The same techniques work for suicidal ideation and suicidality as well?
Right. So what you're asking about is, in most cases, is a comorbid disorder, which is they have an underlying depressive disorder and they have a comorbid substance use disorder. Yeah, we see it pretty common. It happens in people, but not like every other person is suffering from it. But the people who have comorbid, many a times they're struggling with depression, and then they started using drugs. So you have to treat both to get better. So you're treating the addiction on one end, and then you have to address the depression with the treatments that we have available. Now, either you can do it, or you can send them separately to another psychiatrist to manage depression, which is fine. You can coordinate the care with them, but a lot of psychiatrists will manage both disorders. But addiction is also treated by other practitioners, like family practitioner, people from internal medicine. They can do addiction medicine fashion, they can do it. So in that case, they would refer the patient for psychiatric illnesses to a psychiatrist, and then we will treat their depression separately with therapy, with medication, and then their substance use disorder separately.
Perfect, thank you.
Okay, Dr. Nauman Ashraf, I want to ask, can you hear me now?
Yeah.
Yeah, okay. I want to ask about this, I mean, after legalization.
Dr. Fozia cannot hear you. You can maybe write your question.
So is there some work done on any brain changes in just like, okay, go ahead.
Okay, so you are asking about, I heard the legalization and any work done on the brain changes. Just type your question.
Yes, legalization of marijuana and any
Yeah.
work done on brain changes.
Right. Okay. So marijuana is pretty much state. So at the federal level is still illegal, right? And there's a proposal to change it to Schedule 3. So, but at this point it's illegal federally. State-wise, I think there are only three unfortunate ones that have not made it legal, but most of the places there's some sort of use. Either you can get recreationally or you can get it for medical use. And there are different types of marijuana. So we can have a lecture on marijuana later on, but it's a CBD and the THC compound. So like in Texas, they have a low CBD license that's separate. Some states would let you grow your marijuana and they have some quantities limits on them. So state-wise, you can use it. Legally, it's still an illegal substance. Now, changes in the brain, that's a great question. So there's a study that's started federally. It's called ABCD study. And they are going to study the brains of people from the teenage, take the people or the kids, teenagers who have not used anything from the schools, recruit them and see how many use with what kind of drug. It could be cocaine, it could be marijuana, it could be anything. It's going to be a decade long and maybe longer, and then do all the tests on them. It's the biomarkers, screening, whatever needs to be done, imaging, and then find out what is the course of the disease and effect on the brain. So we will know more about it with this study when this ends. This is the one that's great. So I would say you guys should read up on that. It's called ABCD study. You should Google it, it'll come up.
Amazing. Thank you.
Thank you
Thank you
very
so
much.
much, Dr. Ashraf. Okay, we will take the last two questions now. One from Dr. Asim and the other from Dr. Adam Kazi. So Dr. Adam Kazi, are you here with us? If you are, just unmute your mic and ask your question.
Okay, thank you. Yes, as the doctor has already described, that there have been brain changes after substance use. Is there any evidence of reversible of these changes?
Right. So the one that I showed in the methamphetamine study, that was very clear that there are changes in the brain and then they would reverse if they are abstinent for 14 months. So there's hope. Yes, the changes can reverse. But again, it's early for all drugs. That's why they're doing this study on the adolescent brain study, so they can find out more about it.
Thank you.
Perfect. Okay, Dr. Asim and Dr. Rizwana, I think then we will wrap it up.
We're speaking a little bit about marijuana here and how it's become legal in many states. Have we, as mental health practitioners, should we anticipate an increase of incidence in psychotic disorders, depression, or anxiety with more people using marijuana or it being accessible legally in the future? Thank you.
Right. So with marijuana, it's interesting. There is a combination issue. There's a strain issue of what you're using because it's not legal enough way where it's studied like say Zoloft or like aspirin, where a pharmaceutical company has studied what is the ratio, what are the side effects, how much you take when you take it, what happens to your body. So it's like people are growing it and then dispensaries are giving it to you. So you don't know what is inside that marijuana. So because of that, there's so much variability that that you will see depression and you would see anxiety. Some strains, some people say, I feel better in terms of my anxiety. They may have some more of a CBD side than the THC. Some say they get panic attack, really bad panic attack. Similarly, depression, long-term use causes depression. Psychosis, you will see psychosis. People feel paranoid when they use it. The one interesting argument around schizophrenia is, so psychosis can be any psychotic disorder. But if you typically talk about schizophrenia, then one argument is schizophrenia prevalence has always stayed at 1% for years in the community, but marijuana use has gone up significantly over time. So why that is not reflecting in the schizophrenia prevalence or incidence? The reason for that, people, how they explain it is maybe because we are seeing more and more people coming with psychosis and schizophrenia, maybe the ones who were destined to, or they had the brain wired in a way that they were going to have a schizophrenia later in life, like say 20, 22, 23, Now, with the use of marijuana, remember the double hit hypothesis. So it's manifesting earlier, like 16, 17, 18. So we're getting those people earlier, but the overall prevalence remains the same. So they have more burden of the disease, basically. So that's one controversial thing on schizophrenia, but definitely it causes psychosis. You will see psychosis, you see depression, you're going to see more anxiety.
Thank you.
Dr. Rizwana, you can go ahead and ask your question, and then we'll wrap it up.
Thank you. Dr. Nauman, as you mentioned previously that whenever the kids, their school grades are dropping, either can be psychiatric element or they can be an addiction element. But I had seen that many kids' grades, they dropped while they went from in-person learning to virtual learning. And they got better when they went back to the in-person learning. So is there still can be some psychiatric problem or the addiction problem?
No, I mean, that would be totally separate, right? So, so virtual learning, the problem is a lot of kids are not paying attention. They will have their cameras turned off, and virtual, what we have noticed is they're playing games, they're chatting with others. And in the classroom, there's more one-on-one attention. So that may be the simple thing to look at before you look at other things. So I think the way to tease it apart is if someone wants to do study is asking the parents, if you were with your kids when they were doing virtual learning and you monitored them versus people who were left and the parents did not monitor, how did it affect their learning? Because there shouldn't be much of a difference. Of course, in person is better. You pay one-on-one attention, but I mean, the future is virtual learning. A lot of people are able to learn, but they have to pay attention. But the kids, unfortunately, they get distracted and they're not paying attention.
Thank you.
Great. Thank you so much. It was a wonderful session. Dr. Fozia, can you hear me? Okay. Dr. Fozia, I don't know. I think she is here, but she is unable to hear me out. Okay. So I guess we have covered all the questions from our chat. And Dr. Nauman, do you want to have more questions or should we wrap it up?
If you have, we can take one more question if there's an important question. Otherwise, we can wrap it up.
Okay, Dr. Sadia, you can go ahead and ask a question.
Welcome, Dr. Ashraf. Thank you for the amazing lecture. I just have a question. In the real world, Dr. Ashraf, what are the common causes of relapses and how do we tackle those? I mean, just in the real world.
So there are three categories that you have to train your patients to be careful about. That's why when I said we utilize CBT, so they're monitoring their thought process. So there are three things, and they talk about in the AA meetings on that: people, place, and things. So people means the people that you used to use drugs with. So if there's a circle of friends, you have to avoid them and find new friendships, like what we call people who are abstinent. You need to hang out with them. Places, if there's a place where you used to go and that was the place where you used to use, there are chances if you go back there, your memories are going to come back, and again it'll become like a conditioned response and you would use more. So they're recommended not to do it. So sometime what happens, there's a treatment what we call family network therapy. In that therapy, it's the patient but also involve other significant people from patient's family that the patient says, okay, I trust them and I want them to be part of my treatment. So it could be patient's spouse, could be their mom, dad, could be their friends. And now suppose the patient is a CEO and he used to go to, say, Vegas and for meetings, but at night would use drugs. And now he has to go to a meeting, but he's been abstinent and not been using, he's in treatment. Now he's worried that if I go, I'm going to be alone, I'm going to be in the same place, I may end up using. So sometimes the plan is that someone from that network family goes with the patient, stays with them, makes sure they're not using drugs. So that's how you do it. And the last one is things. Things are unfortunately that happen in life: breakups, poverty, somebody dies in the family, funerals. So how do you do the deal with it? So you prep them, and also you have a network of people who can help them out. So if this happens, reach out to us, reach out to your therapist, reach out to your counselor. Like in our program, we have a crisis hotline 24/7. If you have problem, call us so somebody can reach out to you, talk to you. If we feel like they're at a point where they may have a relapse or they need help, bring them in, help them out, keep them inpatient. So that's how you protect them.
Thank you so much. So then again, the whole biopsychosocial model is very important, right? Because we're trying to figure out what are the sort of,
Yep.
Thank you so much, Dr. Ashraf. Thank you.
Over to you, Dr. Arang. I hope we can.
I hope it's working now. These internet issues. Is it working now?
Yes.
Yeah, maybe if like you can just turn off your video, maybe that's how it would work better.
Okay.
Yeah.
So we are
Just turn off your video. Your internet will be fine.
about to finish now. So I would like to wrap up. Doctor, okay, so
You need to now unmute yourself.
Yeah, you are muted, Dr. Fozia.
I have invited Dr. Rizwan Asim.
Sorry, Dr. Fozia, I couldn't hear you. I just heard my name.
No,
Yeah,
I think
you raised your hand. Do you want to ask something?
No. I actually raised previously when you already told me to ask the question. I asked my question already.
Okay, Dr. Fozia, up to you. I think we should wrap it up.
Yes. So I can see Rahil Memon here. I will invite him. How did he find the lecture? And we are really thankful to Dr. Nauman Ashraf for taking out time and for this wonderful, wonderful lecture.
Thank
Dr.
you.
Rahil Memon.
Assalamu alaikum, everyone. Thank you, Dr. Nauman, and entire panel for holding this a great discussion over the weekend. Dr. Nauman, this was very informative, especially with all the pathways. I think those who are getting into residency and then those who are applying, or even those who are residents and fellows, I think this was very amazing presentation. I hope people, there are a couple of take-home messages for those who are practicing. And I think Papana, and I hope that Papana will continue to arrange these kind of seminars more often so that, we can learn together. Just one suggestion that if we can create a poll for future, that what kind of lectures, people want, and then, we can arrange those lectures, and I'll be more than happy to be part of it. And I hope everyone will enjoy their weekend and can go to eat those all payas and biryanis that Dr. Ashraf earlier. Thank you, everyone. Thanks for coming.
Thank you very much. Thank you very much. Thank you very much, Dr. Nauman Ashraf. Any closing remarks you want to give?
Well, I'm gonna type it, but I just want to say good luck to all of you, whoever is applying and whoever is in the process. The math cycle is I think it's gonna, you guys would probably be working on your process segment and CVs. So good luck to everyone. I know that Papana has done the seminars on that prep too, so they'll probably be doing those seminars. It was great. It was great being here, interacting with all of you. There were some great questions, and then hopefully in the future we can do some talks on other topics too. I think opioids is very important. Marijuana is very important. People have a lot of questions about it, so we can probably address those too.
Thank you very much. Thank you.
Great. Thank you.
Thank you.
Thank you, everyone. Goodbye.
Yes, Dr. Nauman Ashraf, Rahil, just stay for a while.
Okay.
Okay.
Bye.
Yes.
Many thanks.